Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very handy in your line of duty. So I welcome you all to part 122 of our Pharmacotherapy MCQ series, which measures in infectious diseases. Welcome. The first question reads, Mr. H.P.B, a 45-year-old male patient, presents to your accident and emergency department with a chief complaint of severe acute abdominal pain, which is located on the lower right quadrant. He's also nauseated, he's vomiting, and he's been vomiting for the past few days. He has a past medical history of hypertension, which is controlled on medication, and he hasn't had recent hospitalization. He has no known drug or food allergies, and the team opts to do a CT abdomen, which shows free air, which points to a perforated appendix. He is rushed to the operation room for an appendectomy with peritoneal washout. So my question to you is, with which of the antibiotics listed below would you treat Mr. H.P.B post-operatively after he returns from surgery? Would you treat him with moxifloxacin? Or would you settle for piperacillin tazobactam? Or would you settle for ceftriaxone? Or would you prefer ertapenem with metronidazole? I'll give you 10 seconds to choose the correct answer. I would opt to treat this gentleman with moxifloxacin post-operatively. Now, moxifloxacin is the guideline recommended treatment for community-acquired appendicitis. Remember that. Now, ertapenem already has anaerobic coverage, so metronidazole would not be needed. That would be therapeutic deprecation, bad antimicrobial stewardship. Therefore, I would not settle for alternative D. Now, ceftriaxone does not have anaerobic coverage, so it makes it an unsuitable choice, making answer C wrong. Then piperacillin tazobactam covers healthcare-associated pathogens that would not be applicable in this gentleman's case. Let's move to the next question, please. And it reads, for how long would you treat Mr. H.P.B with the antibiotic chosen in the above clinical case? Would it be for 7 to 14 days? Would you treat for 7 to 8 days? Would you treat for 4 to 5 days? Or would you administer a single dose? I'll give you 10 seconds to choose the correct answer. I would treat him for 4 to 5 days, and this is based on the Stop It trial, STOP-IT trial, And that, according to that trial or its outcomes, a treatment duration of 4 to 5 days would be recommended for such a patient. I would recommend you read about the Stop It trial for further information. Let's move to the next question, please. And it reads, Mrs. H.W.K., a 69-year-old female patient, was admitted to your general medical ward 14 days ago due to spontaneous acute pancreatitis. She has a past medical history of several hospitalizations. She's an IV drug abuser, and she has alcoholic liver disease. And the peritoneal fluid was analyzed, and it showed PMNs, and the count was equal to or above 250 cells per mm cubed. She has been on parenteral nutrition, and a central venous catheter has also been placed. And you establish that the patient has no known drug or food allergies. And then 4 days ago, she was empirically initiated on Meropenem and vancomycin at your hospital. This morning, she began spiking fevers of 102.4 degrees Fahrenheit, and she also had elevated WBC counts. Blood cultures are still pending. So my question to you is, which of the therapeutic modifications listed below would you recommend in the case of the HWK now? Would you choose to add Micafungin to Meropenem and vancomycin? Or would you choose to add fluconazole to Meropenem and vancomycin? Or would you choose to add colistin to Meropenem and vancomycin? Or would you choose to stop both Meropenem and vancomycin and initiate ceftolozane tazobactam? I'll give you 10 seconds to choose the correct answer. I would add Micafungin to Meropenem and vancomycin, and I'll tell you why. This patient is at a high risk for systemic candidiasis given the receipt of broad-spectrum antibiotics and even the total parenteral nutrition and the continued sepsis. Now, treatment with an echinocandin antifungal is recommended due to the severe disease presentation in this particular case. Let's move to the next question. And it reads, 14 days later, HWK has recovered and is ready for discharge. So my question to you is, which of the prophylactic regimens listed below would be the most appropriate for HWK for secondary spontaneous bacterial peritonitis? Would it be lifelong prophylaxis with ampicillin sulbactam? Or would it be 6-month prophylaxis with cotrimoxazole, Septrin? Or would it be lifelong prophylaxis with Septrin? Or would it be prophylaxis is not warranted at all? I'll give you 10 seconds to choose the correct answer. I would opt to do lifelong prophylaxis with cotrimoxazole, Septrim or Bactrim. Now, in patients who survive an acute infection of spontaneous bacterial peritonitis, lifelong therapy with either cotrimoxazole or a fluoroquinolone, such as norfloxacin, is recommended and it's mentioned in guidelines. The other options there are wrong. Let's move to the next slide, please. And it reads, Mrs. TMC, a 36-year-old female patient, had a root canal procedure done at your dental clinic a week ago. She took 3 doses of clindamycin orally, and today she presents to your hospital with a chief complaint of voluminous diarrhea. She has 4 to 5 unformed bowel movements on a daily basis. She also has moderate abdominal pain, and she rates it as a 6 on a scale of 1 to 10. She is a febrile, and a stool diagnostic test is done, which turns positive for Clostridioides difficile toxins. And that was a PCR, to be specific. So my question to you is, which of the recommendations listed below would be the most appropriate for Mrs. TMC now? Is it true that the patient is at a high risk for recurrence Clostridioides difficile, so we should start fidaxomicin now? Or is it true that the patient has Clostridioides difficile infection, so we should start vancomycin administered as an oral suspension at a dose of 125 milligrams 4 times daily? Or is it true that the patient has mild to moderate Clostridioides difficile infection and we should start metronidazole? Or is it true that the patient is likely colonized with Clostridioides difficile according to the PCR diagnostic used, and no treatment is therefore necessary? I'll give you 10 seconds to choose the correct answer. So this patient has Clostridioides difficile infection and we should start vancomycin oral suspension right away. The patient is at a risk of or for Clostridioides infection due to her prior exposure to a high-risk antibiotic, which is clindamycin in this case, and has signs and symptoms which are consistent with the disease. Now, according to the 2017 IDSA SHARE guidelines, treatment with vancomycin is recommended as this particular patient has no risk factors for recurrent Clostridioides difficile infection. Let's move to the next question, please. And the next question reads, Mrs. JAL, a 58-year-old female patient, presents to your accident and emergency, complaining of severe acute abdominal pain in the lower right quadrant. She is nauseated and she is vomiting. She has a past medical history of end-stage renal disease, type 2 diabetes mellitus, and breast cancer, for which she is receiving oral chemotherapy. She has had no recent hospitalizations. She has no known drug or food allergies. And the team chooses to do an abdominal CT, which shows free air that is suggestive of a perforated appendix. She is emergently rushed to the operation room, where she undergoes an appendectomy with peritoneal washout because of gross contamination, accompanied by diffuse peritonitis. So my question to you is, which of the statements listed below most accurately describes Mrs. JAL's intra-abdominal infection? Is this a case of an uncomplicated community-acquired appendicitis? Or is it a healthcare-associated infection? Or is it a high-risk community-acquired infection? Or is it a community-acquired infection of mild to moderate severity? I'll give you 10 seconds to choose the correct answer. C is the correct answer. This is a case of high-risk community-acquired infection. Now, this patient has not had recent exposure to healthcare system and is thus considered to have a community-acquired infection. Now, her end-stage renal disease and other comorbid conditions put her in the high-risk category. So those two statements justify why I would settle for C, high-risk community-acquired infection. Let's move to the next question, please. And it reads, PMM, a 32-year-old patient, presents to your clinic with a high-risk community-acquired or complicated appendicitis. My question to you is, which of the regimens listed below would be the most appropriate for the management of this clinical case? Would it be Piperacillin tazobactam, or would it be cefepime, or would you settle for cefoxitin, or would you choose to infuse ceftriaxone and metronidazole? I'll give you 10 seconds to choose the correct answer. I would prefer to treat this patient with Piperacillin tazobactam. I'd like to start by saying that patients with high-risk community-acquired infections should be treated with an antibiotic with anti-pseudomonas and anaerobic coverage. Remember, you have to cover Pseudomonas and the anaerobic bacteria. Now, ceftriaxone and cefoxitin do not have anti-pseudomonas coverage, and then cefepime does not have anaerobic coverage. So only Piperacillin tazobactam has both anaerobic bacteria coverage and anti-pseudomonas coverage. So that makes it the best alternative. Let's move to the next question, please. And it refers to the same patient above. PMM is clinically improving 2 days after undergoing an appendectomy and being initiated on the appropriate antibiotic therapy. So my question to you is, for how long would you treat PMM with this antibiotic? Would you treat for 7 to 10 days? Would you treat for 8 days? Would you treat for 4 days? Or would you treat for 2 days? After which therapy can be discontinued immediately. I'll give you 10 seconds to choose the correct answer. I would treat this fellow for 4 days. Now, the stoppage trial that I referred to earlier demonstrated that 4 days of therapy was as effective as 8 days of therapy. And no study has demonstrated that less than 4 days of therapy is less effective. Thus, C, which is 4 days, is the correct answer. 2 days would be too short. 8 days would be unnecessarily long. Even A would be unnecessarily prolonged therapy. So long as it's a proper washout, 4 days would be just fine. So ladies and gentlemen, my highly esteemed viewers and listeners, that brings us to the end of this brief video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, to share it widely with your peers, and to leave a comment at the bottom of the video. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. would like to promise you that the very, very best is yet to come. Thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you in subsequent videos. Thank you very much.